being here. It's a pleasure to introduce today's speaker, Dr. Ellen Eaton, who's an assistant professor in the Department of Medicine, Division of Infectious Disease. And she's going to talk today about the impact of economics on what we do in medicine and how decisions around cost bear on how policies are developed. That's a reasonable way of saying it. This is a really, really important area. I don't know if several of you may have been into the medicine grand rounds that was within the last 3 or 4 months where someone talked about the impact of different models of decision making on how national payer programs work. And we're at the point where people it's clear that the cost of the medical care we give is really unsustainable and is putting a burden on our society that's unbearable. And so people have to make decisions about, what the value of a disease-free year is for somebody, what the value of an extra year of life, but with different kinds of disability are. So that's a sort of ethical kind of problem. But before that, there's even just the understanding the finances of what is going on to be able to make those kind of ethical decisions. And so hope you'll get an eye into this. Dr. Eaton, I just want to highlight, took an initiative here. So she was funded for a couple of years through the PCORI K-12 program. It's an early career development award that I don't think he maybe has anymore. Okay. Actually don't know. Anyway, we hope PCORI will continue to exist. It's under some threat now to be discontinued, but I think the signs are pointing relatively positively that it'll still exist. If you ever have the opportunity to talk to any of your elected representatives, please encourage them to keep PCORI as a valuable research arm of the U.S. government. It's really does things that no other part of our funding system do in terms of defining best outcomes, best practices for best outcomes in healthcare. So she had that funding, and then she took the initiative to get a fellowship through the National Academy of Medicine, which is a 2-year fellowship that again is a career development award that has to do with public policy around medical issues. And if you're interested in how to ferret out those kind of programs, you might want to talk to her a little bit about it. She did get some help from the CCTS, but took a lot of individual initiative to make that happen. So please use her as a resource. So anyway, I'll turn it over. Thanks very much.
Thank you for that introduction. Can you all hear me? Okay, great. And if at any point I trail off, or if you see chat messages come up, questions on the screen, please direct my attention to those. So I am one of your peers, early career clinician investigator. I just wanted to give full disclosure, this talk has traditionally been given by my late mentor, Dr. Meredith Kilgore, whom some of you may know. Really a tragic loss to UAB that he passed away in the last year. A lot of the slides are his. And I've adapted them and included examples from my work. And I'll be happy to refer you to additional resources, but I'm just saying that to say it's hard to follow an expert, a nationally recognized expert who does Medicare claims data and a lot of other impressive research in this field. But if I don't know the answer to your question, I'm happy to refer you to additional references and resources on campus. Just a show of hands, how many of you all are clinicians? A few clinicians, okay. How many of you have background either taking a course in cost effectiveness or medical decision making? Okay, it just helps me a little bit in the back, okay, understand what our group is and where to aim for the next hour and a half. I should have plenty of time for questions, so feel free to interrupt me with questions as we go along. So the reason we're here today, we're going to talk about why economic evaluations are important. We're going to talk about different approaches to economic evaluation. We're going to talk about decision analyses, and within decision analyses, specifically cost effectiveness and cost utility analyses. I hope to give some examples that will inform your work. And I also just want to encourage you all to look at some of the references I provide, but also really view the literature as your teacher. A field that is so new, evolving, relatively niche. I'd say my second mentor in addition to Dr. Kilgore was really the literature. And even if work has not been done in HIV, which is where I work, there are often examples in diabetes or heart failure that you can use the same methods to inform your work. So I think examples here are really a great teacher to augment your work. So uncertainty. We're all interested in uncertainty, whether we're researchers or clinicians. We know that a lot of the care we provide has uncertain risks, uncertain outcomes. We may have estimates based on the literature and other cohorts, maybe in our cohort, but we can all acknowledge that there still remains a great deal of uncertainty in medical care. And then this type of work came out of a need to make choices. So we often have competing objectives between improving health, but avoiding adverse outcomes, avoiding surgical complications, for example. And then lastly, it's important for us all to remember that even in a developed country in 2019, there are scarce resources. We see this in the news, in the lay press, how our spending is out of control with regards to healthcare dollars. And we are certainly an outlier in terms of the US. So it's really important for us to consider scarce resources, personnel, pharmaceutical products, et cetera, when we're making plans for patient care and when we're pursuing research. So a lot of cost effectiveness modeling relies on disease probabilities, estimates that, as I mentioned, may come from your cohort, may come from other cohorts. And then even the tests that we use to diagnose patients have test characteristics, sensitivity, specificity, for example, that may vary from one population to another, from one disease state to another. And in addition, the probability that our interventions as clinicians will lead to a cure or an improvement or a complication, these are all based on probabilities that we can derive from the literature. A lot of these estimates, if they are not present in the literature, can be a deal breaker for your research. So for example, if you are someone who studies a very rare disease, in order to build a cost effectiveness model, you really need estimates on the probability of that disease, on the success or failure of specific tests for diagnosing those diseases. So things like HIV, heart failure, diabetes, I'm giving these examples because there are a lot of data on disease outcomes, test performance characteristics in these pretty common disease states. However, if you're studying juvenile RA, maybe a pediatric population, maybe a more rare condition, it may be hard to do your cost effectiveness models if someone hasn't gone before you and developed those estimates of probability of disease outcomes, test characteristics, surgical outcomes, for example. That doesn't mean you can't be the one to develop those outcomes and to build a cohort and to disseminate those findings for others to build on their cost effectiveness and health outcomes models. But I just want to lay that out there. If you do study a very rare disease condition, you may be more limited in what you can do without building without having your own preliminary data. So why do we do economic evaluation? I think you all probably have a general idea in even being present here. We have to make decisions, treat or don't treat. Which treatment if there are multiple treatments? In my field in HIV, we have hundreds of treatments for HIV. So then we have to think about cost, health outcomes, cost effectiveness. But also our health systems are making these decisions, what facilities to fund. Are we going to invest in another outpatient surgical center? Or are we going to invest in a new clinic for Children's Hospital? And then the NIH and other funders, CCTS even makes these decisions when they decide what research to fund. What is their bang for their buck going to be? So even outside of the clinical realm, in medicine and in science in general, these decisions are being made based on the economics. How much are we going to put in and how much juice will we get for the squeeze, for example? So hopefully I've convinced you why economic evaluation in healthcare is important. Scarcity. In an academic health center, I think it's pretty obvious to us the limited resources. A lot of us that provide patient care are making these decisions on a day-to-day basis. There are, at any given time, multiple people throughout Birmingham and the state of Alabama who want a bed at UAB Hospital. If you're involved in triaging those decisions, who can and cannot get a bed at UAB, that's a perfect example of scarcity that even exists in 2019 in a well-resourced country. There are opportunity costs. For every person that we take to the OR, that's someone else who doesn't get to go to the OR. For every person that we sign up for charity care, that's someone who doesn't get charity care, who remains uninsured, who then falls through potentially the healthcare cracks and doesn't get treatment. So that is truly opportunity costs. And this, I think, is a really nice quote. Economics is the study of how societies use scarce resources to produce valuable commodities and distribute them among different people. And I'm going to give you some examples along the way as we talk about different models of evaluation. But I'm sure you can also think of some from your work, whether you're a researcher, trainee, or clinician investigator. So this is a great quote. You can't always get what you want. And I did not know until I took Dr. Kilgore's class that Mick Jagger actually trained at London School of Economics before he went on to be a musician. And there's a whole Forbes article on all the lessons that we can learn from Mick Jagger through his lyrics. So he actually does have formal training, and I think we all can appreciate that we can't always get what we want. He did go on to say, if you persist, if you try hard, you might get what you need. I think all of us as researchers, early career folks, can agree with persistence does often pay off, maybe not as soon as we'd want, but we can learn a lot from him. So the types of economic evaluation. So you've probably heard these terms. Cost minimization is just the concern of how can we get costs down. So you're really just thinking about efficiency, whether it's reducing length of stay, whether it is reducing elective procedures. You can think of many examples. Cost effectiveness analysis, and a lot of people do interchange cost utility analysis and cost effectiveness analysis. Even in the literature, these two are interchanged. Really, when you think about cost effectiveness, it's any dollar amount per health outcome that is usually a positive outcome. So it could be infections averted, infections prevented, lives saved, life years gained. Thinking about cost utility analysis really requires that you have utility built in terms of quality adjusted life year or disability adjusted life year. So qualities or dailies. I see some head shaking. Are people familiar with quality adjusted life year? Have you heard that term in the literature? We'll talk a little bit more about that. Just wanted to get a sense of how much in depth we need to go in future slides. And then cost benefit analysis is really just saying for X amount of dollars, we did Y. Less sophisticated, but is very intuitive and can be very helpful to inform decisions in my work, like health systems. If we provide this intervention for 10 people, we can save, $50,000 over the next 2 years. Very intuitive analysis. Examples. So this is some work that I did with the hospital, actually looking at an intervention for persons who inject drugs. So for those of you that are clinicians, or for those that are reading NPR, you know that we're in the midst of an opioid epidemic. We have a lot of injection drug users being in the foothills of Appalachia here in Alabama, and a majority of these patients are uninsured or partially insured. So a lot of health systems are footing the bill for these patients. And imagine our rural hospitals are seeing a lot more of this than even we are. Walker County, for example, where there's a lot of injection drug use. So our health system and our physicians wanted to develop an intervention to say, at what point can we safely discharge these people? Our inclination is that we need to keep them in the hospital for weeks to months at a time because they are at high risk for substance use disorders, recurrent infections, homelessness, etc. However, when we're keeping these people in the hospital for 4, 6 weeks, 8 months, these patients accrue a lot of healthcare dollars. So there was an intervention that was to reduce length of stay. And this is a very simple analysis just to show that this kind of research does not have to be very sophisticated. We did this in Excel. There was no modeling. There was no Markov model. But basically we said, if we can provide this intervention to N people, we reduce the average length of stay for all comers by 22 days. What did that translate into? Health system dollars, the hospital dollars. It reduced hospital dollars or hospital spending by 33%. So we looked at we actually looked at their billing data. These weren't like estimations. We estimated cost $100,000. This was like actually looking at the bills that went through UAB's financial accounting office. So we saw that we reduced costs by 33%. And then we said, well, if in treating 100 people, we reduced the average length of stay by 22 days. what did we create? What was the opportunity cost that we then were able to take advantage of? Okay, 22 days in the hospital. We found out that the average length of stay for other people was 6 days. So if you have 22 extra days for each admission, then that means you can fit 3 additional admissions within that 22-day period. So you've just freed up beds for 3 additional patients for every 1 patient that receives this intervention. Again, this is not rocket science. This is like calculations in Excel. But it showed the health system that they're actually not just safely discharging people early and saving costs on this patient population, they're increasing capacity for other patients. Did you have a question?
Yes. So when you say safely discharged, what data are collected kind of long-term to know whether these people, fell into readmission or having
readmissions? That was what we looked at. We did not see significant increases in readmissions. And that's a great question, because in all of these analyses, you want to make sure you're not doing harm, right? You can't do anything solely based on the economic argument. You have to prove that you're actually promoting health and wellness at the same time. So yeah, we looked at readmissions and showed that with this intervention, we did not see an increase in readmissions. So that's a great question. So I'm going to put some references at the bottom. If you have questions and you're like, hey, I'm interested in doing X, I'm happy to share some references of stuff that we've done at UAB and other examples, bless you, of stuff that's been done in that space if I'm aware of them. Okay. Another cost effectiveness analysis, that previous example was more of a cost minimization. This is more of a cost effectiveness analysis. And the types of models here, nobody's going to quiz you at the end, so don't worry about them. I just wanted to give you some examples to trigger your own thoughts and hypotheses about what you could do in your line of research. So for HIV, we have multiple first-line safe antiretrovirals. Most of them are very costly. The frustrating thing to us as clinicians is that as each new drug is introduced, it comes in at a very high price, and there are a lot of very early adopters who switch all their patients from the old tried and true medication that is, potentially even going generic in the future to this new hot, sexy drug that may be, $10,000 more a month, for example. So I did this analysis during my postdoc, looking at dollars spent for the initial treatment course. And what we did is we looked at everybody who's treatment naive, starting therapy on one of 10 first-line regimens to see how long until they switched. And the switch could be any reason. They failed it, their virus did not suppress or increased after initially suppressing. They had a side effect, they had a toxicity. So our cost was the cost of providing this pharmaceutical treatment, and our outcome was time to discontinuation. So that you could say, hopefully, following this study, what am I going to get the most bang for my buck for in terms of treatment-naive HIV-infected persons? And that was a very simple analysis. I'm happy to share that with you. I think that HIV is nuanced. A lot of you probably don't evaluate treatments for your populations based on time to failure, but because HIV, we want to get people suppressed, and we have a very clear marker of viral load suppression. Time to suppression and time to failure are metrics that matter to HIV. They may not be as relevant in diabetes, et cetera. But that was a very straightforward. I took Dr. Kilgore's class. I did this project for a requirement for the class, and we turned it into a publication because as was mentioned earlier, health policy is really driven by cost effectiveness analyses, and actually published it in a journal that has a bigger European audience, which is not coincidental. A lot of European healthcare systems have universal healthcare, and for that reason, they keep much better tabs on, if they're writing the checks, they know how much these drugs cost and what they're getting out of them in terms of patient outcomes. So that's also something to consider when you're publishing, is knowing that the right audience to disseminate your science through. And again, this was a very simple analysis, a brief report, one figure, and showed that really some of our newer drugs aren't worth, shocker, the excessive cost that they come through when initially FDA approved. Yeah.
When you do that cost analysis, when you try to find out the cost of the drug, there's so many different things you could look at. You could look at what does a Medicaid patient pay out of pocket, what do they bill to insurance, what do you think you've got no insurance. So when you do that cost effectiveness analysis, what cost of the drug did you use?
So that's a great question. We're going to talk about perspective, because anytime you talk about cost to whom? Cost to the patient? Is it out-of-pocket cost? Is it cost to Ryan White federal programs, Medicaid, et cetera? So for this, we did average wholesale price of the actual drug. And then within the limitations of course, you have to state, no one really pays the average wholesale price. But we have to have some estimate that is consistent across all the drugs. And then we adjusted for, I think we adjusted for the year. Maybe we didn't have the data available in 2017, so we had to adjust to US to maybe 2017 US dollars. So you want to be consistent in your methods and how you're determining the actual cost. And you have to be very clear in your introduction. Here's my hypothesis from this perspective, from this payer's perspective. That's a great point. So in assessing treatments or programs, we often ask, does it work? So in controlled clinical trial settings, we think about efficacy. In usual care settings, we talk about effectiveness. And in an economic context, we think about the cost effectiveness. And then finally, when we're thinking about the economic evaluation, we're going to ask ourselves, who's paying, who benefits, and in many cases, you have to pick one, but often more than one people are, there's secondary insurers, there's an insurer paying and a patient out-of-pocket costs, copays, et cetera. So it is often much more complicated than we can write about and share in our science. So this is a nice segue to your question. So you can think of societal costs. And a lot of the large studies from the National Health Services in the UK and other Spanish countries, for example, publishing from their society's viewpoint, especially if they have a single payer system. You can think about a government agency. You could think about the VA. You could think about your insurer, so Medicare, claims data on Medicare beneficiaries. You can think about the hospital or the physician. I've done more work on the health systems perspective, and a lot of that's because a lot of HIV infected patients are uninsured, so a lot of those costs are eaten by the health system, but that is unique to HIV and may not be as relevant depending on the disease states that you all study. And then you can think about the patient or the family perspective, which is becoming more and more important, and funders like PCORI, for example, AHRQ, they are more interested now in out-of-pocket costs, because we know what patients pay is going to determine their adherence to care, is going to determine other measures. If you all, does anybody do cancer research? Okay, so there's a group here, and I'm going to share Gabrielle Rock, one of her slides. She has collaborated with some folks nationally thinking about financial toxicity, which is just thinking of patient out-of-pocket costs as an actual toxicity of treatment, of chemotherapy, for example, that's very costly. And I think that that's very relevant for a lot of us. And this is why it's important to know your funding agency well, know what type of work they're funding. I don't think the NIH is funding that work as much as AHRQ, PCORI, and other funders. And I should say for this last, sorry, am I going the wrong direction? I am. This prior slide, when you think of writing an AIMS page, talk to people about cost as an aim. I have been told not to make a grant title or a specific initial aim related to cost for NIH purposes. I've been told to focus on health outcomes, improving patient care, and then often that cost effectiveness aim is tucked in. It's like a sub-aim, or it's aim number 3. But I've also been told don't put cost in your title. That may be changing, whereas if you go to AHRQ or PCORI, you'll see lots of funded grants that are looking at cost effectiveness. Just a little pearl as you start, writing and incorporating this type of work into your research. Okay. So I think we finished that, yeah, patient and family perspective. So context, policies, locations, really important. You all have probably thought about this. Thinking about HIV, and I apologize, that's the work I do, so I give a lot of HIV-related examples. We don't do a lot of Medicare claims data. Why? Because we're just now having a population that's aging old enough to be Medicare beneficiaries. However, a lot of the cancer work is done in Medicare beneficiaries. 340B dollars. Is anybody familiar with 340B funding? So 340B funding they are federal government rebates that health systems and clinics can apply for if they serve a certain percentage or population of indigent, uninsured patients. HIV would be one of them. So many clinics and hospitals that provide care to HIV patients, for example, our 1917 HIV clinic, we can provide medications through our on-site pharmacy at a reduced 340B. We can acquire them in our pharmacy at a reduced cost because we are a 340B affiliated pharmacy. However, we can collect from insurers for our insured patients the actual cost, and we can hold on to that delta. So maybe we get $5 for every prescription that we're able to save. That's an incentive to us. If you have a 3,500 patient HIV clinic, you can accumulate a slush fund. Now, those federal dollars are restricted in terms of what we can use them for. We can use them to improve patient care. We can hire an extra pharmacist. We can, help with interventions for injection drug users. We can't do research with that money. We can do evaluation, programmatic evaluation. But I say this to say that we may look at our 340B funds and the cost effectiveness of using 340B funds to do an intervention for injection drug users. Well, that paper's only going to be relevant to other clinics and health systems who use 340B funds, right? So I'm just using that as an example. Depending on what you study and what disease process you may be an expert in, you may or may not have different types of perspectives. So that's really the government's money, those 340B funds. That's a rebate. We also have Ryan White Care Act funds. So those are safety net funds that the government gives health systems that serve HIV-infected patients. I do a lot of work with Ryan White Care Act funds, but my friends in oncology, I'm speaking a different language. So this is just to say there are different examples depending on what you study of the perspective, and you need to know those, especially if you're not a clinician in that space. It's really important to talk to an administrator of a clinic, a hospital, to make sure you're not forgetting a huge piece of their pie that they use when allocating funds. So it's really important to know who's really paying and how this will impact generalizability. Any questions there? This is important because this is one of the things you have to decide on very, very early when you're writing your grant or you're developing your study. It really informs your hypothesis. Yes?
As having been a patient occasionally, it seems like the way in which costs of care are reported back to the patient is totally impenetrable to rational investigation.
I totally agree.
But is it your experience that hospital administrators are willing to talk to you as a researcher about what their costs really are and how or do they even understand it? And are they open to working with you?
So that's a great question. And I did not talk much about this in the slides, but I have a really wonderful example of working with UAB leadership related to that first example in injection drug users. So I think if you have an issue that is important to many stakeholders, like really resource-intensive patients that aren't providing anything back to the health system, you can reach out to, we had UAB medicine administrators, we had legal, we had risk management, all at the table with hospitalists, addiction medicine, and infectious diseases doctors. This is before my time, but I'm told that all these stakeholders were involved and said, this is a huge problem. We're losing, money talks, we all know that. We're losing a lot of money, but also we can acknowledge these patients aren't getting good care if we don't create some sort of intervention. So I think a lot of people were invested in developing a very comprehensive protocol to free up beds for other sick patients, improve the care of this patient population. And then, of course, there was an interest in studying it and having a formal analysis. So I think that is probably an outlier, because I think a lot of us probably have wanted to get access to, or maybe not, cost data sets. Has anybody tried to get access to cost data? Okay. When I've talked to some other folks on campus who don't have a liaison in administration and billing, financial accounting and billing. Our clinic, I think because our clinic is huge, 3,500 patients, Dr. Raper was able to give me a contact who was willing, once we had IRB approval, to share financial data. I'm happy to talk to anybody if you're interested in that process offline, to think of ways creatively for you to get that actual data. But because our population is uninsured, I can't get Medicare or Medicaid claims, Blue Cross Blue Shield, none of that's really helpful when you have an uninsured population. So you really have to go straight to financial accounting to find out how much they're costing the health system. Any other questions? I think that's a great question though. So as we've mentioned, some disease states predict the payers. I mentioned that HIV clinics can receive Ryan White Care Act funds, and these are federal funds. I mentioned 340B funds. And then also when I mentioned location is important too, thinking about Medicaid expansion versus non-expansion states, these really affect the perspective, especially the health systems. I think I quoted an article recently that 8 hospitals closed in Alabama in the last year, rural hospitals, and that's a trend not just going on in Alabama, but other rural states across the U.S. If you think about the implications of the opioid epidemic and Medicaid non-expansion on rural Appalachia and the Midwest, it's really crippling and not sustainable, unfortunately. So it's important for you to think about these things when you're drafting your study. One paper that I have here as an example, also very intuitive, was looking at this notion of uncompensated mandates, essentially. So if you work with chronic disease or preventive health care, the example I have in this paper is immunizations. So we are required to comply with flu vaccines, pneumovax, multiple vaccine series for HIV-infected populations. If you work with cancer, I'm sure there are other mandates, and there may be your health system, your clinic may get penalized if you do not meet certain metrics in terms of your patients being vaccinated or getting a mammogram, colonoscopy. You can think of multiple other examples. Well, what we did is we just looked at how much we provide in terms of the cost of vaccines and how much we collect. Very simple, very straightforward. How much money do we pay to get all these flu vaccines, all these pneumococcal vaccines? How much do we collect at the patient level? So again, that took getting access to our clinic's financial data. And what we saw is that even when people were insured by Blue Cross Blue Shield, Blue Cross Blue Shield only paid like 80% of the vaccine. So they weren't paying our clinic as much as we were paying for the product. And that, was a high impact paper. The math was not fancy. Again, this was Excel sheets. And based on X percentage, Blue Cross Blue Shield, X Medicare, X Medicaid, X uninsured, here's how much we had to invest in vaccines over 1 year, and here's how much we collected. And look, if we didn't have these Ryan White Care Act dollars, we would go broke. So there's a policy paper for you. Here's, even in a population, even in the subset that were insured, we still ended up footing the bill for 20% of their vaccines. And that type of paper on its own probably won't make ripples. But if that, if God forbid Ryan White Care Act dollars are withheld, this would be something that we could say, hey, look, our patients depend on this. And then you could do another subsequent analysis saying, here's how much it costs to provide hospital care for patients who have HIV who get the flu. You can imagine a whole series of paper that could argue for the importance of these additional safety net funds. Any questions on that? Very simple math here, folks. Like your kids could do this. Okay, decision analyses. So when we hear medical decision-making, decision analyses, it's really anytime you're making choices under uncertainty, and you're often relying on these endpoints, these estimates of probability of health outcomes, probability of complications. It provides a formal framework for making choices. And it assumes that we want to maximize values and minimize costs. That just makes sense, but that isn't inherent within most of the modeling and the software that we can talk about if you have questions about specific software options. So this is an actual decision tree. Raise your hand if you've seen a decision tree, just to get a sense. Okay, great. So you have an initial problem. Your square node shows that you're branching into 2 different choices. And then the health outcomes are the next node, which is the circle node. So you can see for choice 1, you can have a good thing or a bad thing. The probability of the good thing maybe is 90%. That means the probability of the bad thing is 1 minus 90%, right? Because the sum of your options should be 100%. And for most studies that I've done, the good payoff has been very simple. Life 1, death 0. You can also build it to max if you're using a quality adjusted life year to maximize or to maximize qualities, minimize cost. But this is the most simple model of a decision tree. So here's an example. I kept this in because this is very Dr. Kilgore to throw in the coin toss. So if you invited someone to play and you said you can either play or don't play, but if you play this coin toss, you have a 50% chance of head, 50% chance of tails, right? Very straightforward. I'll give you $1. You know, if you win, if you lose, you'll give me $1. So raise your hand if you would play this gamble. Anybody? Oh, so we're very risk averse. We're not interested in giving up $1. Maybe we don't keep cash on hand. That's me. I never have $1. But then it gets more complicated. So if we have a patient coming into the ER and we think they have appendicitis based on our abdominal exam, maybe you're in Rwanda, you don't have access to a CAT scan, maybe you don't have labs, you're going to either have to take this patient to surgery or not. And if you take them to surgery, you need to think about, like, how good are you as a surgeon? What resources do you have? Is it the middle of the night? Do you have staff with you? Do you have antibiotics? What is the chance that they'll die? The chance that they will survive is, of course, 1 minus the probability that they die, right? And then you can think about the options if you don't do surgery. So if you don't do surgery, you have to think about the chance that, hey, maybe you were wrong. Maybe they don't even have appendicitis, right? Because in any decision model, you have to think about every alternate explanation for the scenario, right? So maybe they don't have appendicitis. They're probably going to die. No, they're probably going to survive. Sorry, not die. Maybe they have gas. Maybe they, have a virus. But if they do have appendicitis and you take them to surgery, you again need to think about the surgical outcomes you intend. So this gets a little bit more sophisticated. The next example is when you're in maybe you're at UAB and you have abdominal pain, possibly appendicitis, but you have this test, and that's represented by the second option, okay? And I'm just going to walk you through the second option here. Again, at the very far right, the red triangles are your payout. So 1 represents living, 0 is death. This is very simplified again. So for this test, maybe it's a CAT scan, maybe it's a blood test, some novel blood test. In addition to thinking about the outcomes if you have appendicitis, if the test is positive, you have to think about the sensitivity of the test, right? You have to build in the test characteristics. Combined with what you do, what you act on once you get that test. Because you don't just get a test and say, okay, you have appendicitis, right? You make decisions around that. That's why we're here, right? You get a test result, you either trust it or you don't. If you trust it, you take them to surgery. And then you need to know what the probability is in someone with appendicitis with this test characteristic, whether they'll survive or die. And this same scenario is borne out below it if you don't have appendicitis. You need to have probability estimates in the literature that you can say, you can plug into this tree. So if this, if it's a rare condition, not appendicitis, but some unusual, parasite lodges in your small intestine, you may not have a large cohort of data with probability of surviving X intervention because it's a rare condition. Does that make sense? And I will say there is software available. I didn't get into the software, but there are options that, will help you build this. You still have to make it. You still have to plot down your probability for each choice node and probability node, et cetera. But I'm happy to talk to you offline. I just, for the purpose of today's talk, I didn't get into that. Okay. Here's an example. Actually, Jody's seen this paper. This is a syphilis model that I built. So the question is, for screening for this sexually transmitted infection in an HIV-infected population, should we use the old algorithm or the new algorithm? So for those of you that aren't familiar with syphilis or RPRs, I'll just give a general description. This new testing algorithm was recommended to us, not necessarily HIV-infected populations, but all populations for syphilis screening. In the new algorithm, the initial test is not a treponemal test, so it's not specific. It's very costly. Once it's positive, it's always positive, okay? The old algorithm was very specific. It was less costly, but it only picked up most acute infections, and it missed some people that were kind of late infection. It wasn't a perfect test either. However, in HIV-infected cohort, a lot of these people have been exposed to syphilis in the past. So that initial screening test on the new algorithm will always be positive. It's an ELISA. It costs hundreds of dollars. So the question is, why are we using this new guideline in our patient if we know most of them are going to have that false positive initial test that requires additional confirmatory tests? Well, we did a model with the payout being detected a true case of syphilis. So that was our outcome. That was our survive versus die. We wanted to know in an HIV-infected cohort, based on having this, what I'm going to call a false positive test, what was the trade-off in terms of how much money you're going to pay to have that increased sensitivity at the risk of having costly false positives in a cohort that has a lot of syphilis exposure. Does that make sense? Well, not surprisingly, we found that it was not cost effective to use this new reverse algorithm that was recommended. And I didn't put the tree in here because I couldn't find it. Yeah. And it takes a really long time to build it. But you can imagine it really relied on true syphilis versus, syphilis versus no syphilis. And then it relied on the test characteristics of the old algorithm versus the new. And the chance of, the probability was basically the sensitivity versus the 1 minus sensitivity. Does that make sense? So it really relied on us having literature that showed in HIV-infected cohorts how many would have that false positive ELISA. You probably couldn't do that for a lot of less rare, if you wanted to know the test characteristics in, sex workers in Mexico, you may not have those test characteristics. It hasn't been studied as much as HIV. Does that make sense? So I'm getting back to who is this type of work feasible in? Well, it was feasible because we have a lot of these estimates, probabilities reported in the literature for HIV-infected cohorts. Okay. So again, perspective matters.
I have a question. So
yeah.
So you're sort of getting around the question of how generalizable some of these results are, and for something like syphilis and HIV, is it in general, is the experience in Birmingham the same as that in San Francisco, the same as that in Washington D.C., or?
Yeah, so that's a great question. Yeah, that's a great question. So towards the end of this talk, I'm going to talk about sensitivity analyses, because in any of these models that you run, you also want to show that if you change some of your variables, you don't totally wreck your model. So for example, you may think that your sensitivity of a test is 95%, but then you find a couple papers that show it's as high as 99 and as low as 70. Then a lot of the software that's available now allows you to drop in those alternate options for probability and run that simulation 1,000 times and see how many times does that wreck your model and say, actually, this is cost effective to do this. And that is pretty much expected if you publish this type of work, that you do a sensitivity analysis. And it's great now because there are software that'll just spin that, you drop down your alternate variables for sensitivity, for example, and it will spit out a really nice plot. But that's a great point. And I will say that in that syphilis paper, I think Jody knows this because I think at some point you looked at the paper, it took me like 6 journals to get it published. It's really hard to, the more sophisticated the cost effectiveness analysis, the harder it is to publish. Some of the very intuitive clinical things that I've shown you that I said I did in Excel, those just made sense intuitively. Yes, you have to state your limitations. You know, we're Medicaid non-expansion state. You know, we have some missing data. You have to state your limitations. But when it comes to actual cost effectiveness models, we were doing Markov simulations. I mean, it was clear I was getting very high level PhDs who like wanted me to do this a little different and that a little different. So that's been my personal experience in getting this type of work published, that the very intuitive policy type paper that makes sense to clinicians and administrators and policymakers gets into high level clinical journals. But this one, it took me literally, I think it was 6 or 7 different journals. Some of them didn't even send it out for review. So just cautionary tale. Yeah, Jody.
Can I ask you on that, Ellen? So who do you think the audience is for this type of research? Do you think it's the clinicians who may have some input on which test is done or which treatment is chosen? Do you think it's the policymakers? Because although there's a lot of papers, I don't see enough discussion of which drug to choose and why. So is it both audiences? What do you think?
It's a great point. I think most of mine, the audience is more the clinicians and the policymakers, meaning like clinic administrators, health system leaders. Definitely for the injection drug use one, intervention, the immunization one. The syphilis paper was more of a, yeah, it was really for the clinicians and like the Dr. Rapers, the clinical administrators who are like, hey, you know, this isn't, I still don't think the CDC has formally said, do this new algorithm, but it's obviously been adopted, and all the literature coming out about syphilis now is using this new algorithm. So it was more me as a clinician saying, and this is a trend you'll notice throughout my talk, I get a little frustrated with the early adoption of drugs, of interventions, of testing algorithms, just because we think they're newer, sexier, maybe they're a little more sensitive, but they cost a lot of money. So that's a consistent theme you'll see in my antiretroviral studies, in my testing algorithms. I think that's a general theme in the US, and where we're having so much spending is because we too readily adopt these new policies, tests, medications without studying and quantifying the economic implications. So when I did that paper, I thought, hey, you know, we're doing this new algorithm, and the literature coming from other STD clinics that I know serve a lot of HIV infected patients are using these same algorithms, and they cost a ton of money. Maybe we can do it at UAB and UCSF, but what about, you know, Jefferson County Health Department? So those are the key stakeholders I was thinking of reaching. That said, by the time it got to International Journal of STD and AIDS, I don't know if it has the readership. I was hoping for more clinical audience. So it's a great question. Like, who are you trying to influence? And, or is it simply just a question that needs to be answered? I also thought that was a question that needs to be answered. So, does that answer your question?
Doesn't. Did it influence the policy here?
Yeah, I mean, I think you and Dr. Raper had already started thinking about the back of the envelope math without this formal calculation. And honestly, to influence local change, you just need a back of the envelope. You don't need a formal paper with a Markov model and a probabilistic sensitivity analysis like I was mentioning, where I looked at multiple different options. I think it changed our practice, but convincing other clinics. I haven't talked to other clinics to know. It's really interesting. Here's just like a side note on the review process. It was clear that some of the reviewers that were reviewing my paper before it was accepted were drinking the Kool-Aid on this new algorithm, and they wouldn't even consider the paper because they're like, oh, obviously we're doing this. So I was getting some reviewers who are like, this is really irrelevant to evaluate the economics of this test, which is so much more superior. Yes, sorry.
But, so fundamentally, I think you and I probably think similarly about the issues, but there's the problem that the costs don't stay the same over time. And if, I don't know what the data are actually, but my guess would be that drugs cost a lot when they first come out. They get adopted, they get used more and more.
Mm-hmm.
There's reduction in cost based on the amount of stuff that's being made and economies of scale and stuff. And if you do all your analysis of the cost when it's at its most expensive, you may miss a downstream societal benefit from it once it gets less expensive. And so are there data that allow you to sort of think ahead and not throw out something that could be really good, or at least maybe to make an explicit statement about at what cost would it be worth what it costs. And so could the companies that are involved in producing the drug actually make it for that amount? And be more realistic about
That's a great question. So I will say, most of my work is in HIV, and it's a very artificial economic environment. Because we have these Ryan White dollars, you very rarely see someone, it's not a true market economy. We don't say, I can't afford this new expensive one. We say, oh, you can't afford, we'll chip in, 70% of the cost from this Ryan. So it's not a true market economy. You don't see costs coming down. In addition, the whole generic game is really wacky. So for example, when you see a drug go to generic, a lot of the trade name copay cards and assistant goes away. So patients actually may pay more for the generic than they did for the initial on-brand product. So like everything you learned in economics does not apply here. I think your question is very valid from other perspectives when you don't have all these additional payers involved. But I will say to your second point about models, there are people at Harvard, for example, Rochelle Walensky and her group, who do a lot of modeling before a drug even comes on the market, that say if the drug costs X $1,000 over a year, it is cost effective. But if it costs 2X over a year, it's not cost effective. And that's based on like various inputs about ability to pay for it and adherence and all these other measures that are fluid with respect to changes in pricing. So that type of analysis, there's definitely a place for it. I don't know how much the FDA looks into that or relies on those studies that do incorporate pricing variability before the drug even becomes available. But I think those are very innovative and potentially informative. Now you can imagine you have to have a huge sensitivity on that because a lot of these are done with a ton of uncertainty because they don't rely on a drug that's already been disseminated in, real world outcomes. Maybe they're outcomes based on a cousin drug, or does that make sense? But they are really interesting projections. So, okay. Measuring costs. So we've talked a lot about this already, the perspective, looking at the cost of the initial treatment, but also cost of treating side effects, true cost, charges versus average wholesale price. So I have used in my work for drugs, average wholesale price. For health systems and programmatic interventions, I've looked at the direct charges. It's really hard to calculate indirect charges. Direct charges are things like the cost of the drug, the cost of the syringe, the cost of the vaccine. Indirects would be like, what amount of refrigeration do you need to keep these vaccines cold? Electricity to keep the refrigerator running, like all these other indirects. Even staffing and personnel, knowing what % of your nurse you need to do this is a little hard to do. But it's very rare that you'll have access to true cost. Even when I've asked our lab for the true cost of running these syphilis tests, they're like, we've never gone through and said, like, how much time, what percentage of this lab tech, how much of this assay, we can tell you that our vendor charges us X, So you're always using surrogates that you think are the best. And your reviewer may disagree, and you may have to come run the analysis looking at it a different way, but these are all surrogates. We just have to acknowledge very few of us will know the true cost of something. And then related costs, the savings, I mentioned that initial example where we reduced length of stay, so we freed up 3 beds for every 1 person that got this intervention. So those are, opportunity costs, what you saved. And then there are unrelated costs, and I'll get into a few of these. I thought I had a clock up here. What time is it, you guys? 9. Perfect. Okay. So we're going to be fine on time. Feel free to ask questions. Estimating healthcare costs from the patient perspective. Okay. So it's hard to measure patient out-of-pocket costs for lots of reasons. They're small relative to what the payer may pay. They're hard to calculate. And governments really bear the bulk of direct costs. They fund a lot of the research on cost analyses. So depending on who you are, depending on if you're PCORI funded, if you're even aware of how much your patients are paying out of pocket, You may or may not even think to calculate these. They're very difficult to collect. Has anybody done any work calculating patient out-of-pocket costs, caregiver costs? Okay. So this is an example from Courtney Williams, who's an MSPH who works with cancer outcomes here on campus, and Gabrielle Rock. They've looked at patient cost responsibility. Here's just an example that they shared with me. Their study was looking at guideline concordance, so following the guidelines, and patient costs in metastatic breast cancer and Medicare beneficiaries. So, thinking that I wonder if when physicians prescribe off-label chemo or chemo that is not first line, are we actually seeing patients paying more by going off guidelines? So for their costs, they looked at deductibles, co-insurance, co-payments. Again, this is from a Medicare database. They summed up inpatient, outpatient, physician visits, carriers, durable medical equipment, Part D claims, and then their exposure was that, is the chemo guideline concordant or discordant for the initial chemotherapy? And then they had, obvious limitations, indirect costs that we talked about, hard to measure, transportation, lodging, therapeutic items, lost wages. Can't calculate what the patient paid. So someone asked this question earlier. A lot of times when you get claims data or large data, you can tell someone paid, but you don't know if it was charity care, was it their second insurer, was it the health system? So a lot of this data is messy. I didn't even give the result here because I just wanted to give a framework for how you can ask this type of question incorporating patient responsibility. So what the patient paid, they assumed was based on some metric in the Medicare claims data, but they couldn't 100% say that charity care didn't chip in for that or a second payer. The data just wasn't clear. Does that make sense? So this is an example. I think she's also done some qualitative work where they're asking patients to report on, in the last month, how much have you paid out of pocket for transportation, gas, et cetera, to get to and from doctor's appointments. This is very relevant for us. This is a tertiary care center in Alabama. We have patients who are driving hundreds of miles to get to us. And with cancer, just like HIV, if you can't pay to get there, you can't get the treatment, you're going to have uncontrolled disease, which with HIV, it's a transmissible disease. So it has a lot of repercussions for public health in general. But I'm not aware of anybody doing HIV out-of-pocket costs because I think we have so many safety net funds that we assume that our patients aren't paying a lot. I don't know if that's a rightful assumption, but. So these are real costs to society. Patient costs affect behavior. We've talked about this, adherence, preventive services. I just threw this in here because this is a recent stat that I found from a survey that AIDS Alabama did of injection drug users in the Birmingham area. Of the injection drug users who had HIV, 13 out of 13 missed their HIV care in the last 6 months because they could not pay. Okay, so I'm assuming that they all are getting coverage because of Ryan White and 340B funds. But if you look here, we're seeing that in our area, there are people who likely are injecting drugs and have active HIV viremia. They also, in a later question, told us they're not using sterile syringes. So think about the public health implications of just these 13 people who can't pay to get to their doctor's appointment. So really important. If I haven't impressed on you the importance of this type of research, hopefully you're convinced now. So if you want to collect data on out-of-pocket costs, a few more examples. Think about what types of costs to include. Here we're going to be thinking about US dollars. You need to make sure that if your study is collecting data from 2017, you're going to want to adjust for 2019 dollars. There are plenty of Google calculators. You can do that. You want to think about recall, in-person or phone survey, how long the recall period. The last time I reviewed the literature, I think about 6 months was thought to be as long as patients could actually remember past behaviors, but it certainly would vary if you're studying elderly dementia patients, for example. Diaries, you can have patients fill in diaries. They can record out-of-pocket spending. They can collect their receipts, but just to show the limitations here. Other costs, think about travel, as I mentioned. Think about lost wages for the patient. Think about their companions, their drivers. Is their spouse having to take sick time, and what does that mean for their paycheck? Waiting time, you hear about patients leaving the waiting room frustrated. I waited an hour. Here's a bill for the hour away from my work, and Americans apparently spend $240 billion in time obtaining health care, which is 11% of total expenditures. And that was a study looking at the actual patient themselves, not their unpaid caregiver, for example. Also important to remember that more than 2/3 of care is provided to older adults is provided informally. So not through a paid employed person, but maybe a spouse, maybe a child, a grown child. And then a lot of people provide informal care to someone. 17% of caregivers provide 40 hours or more of care per week. And you can see that these estimates are in the billions in terms of what this is costing society. So when you're thinking about costs, if you want to be comprehensive, you would include both inpatient and outpatient settings. You would want to include drugs. Often this is not possible to get all these costs together. I can say that a lot of clinics on our campus, depending on whether HSF is their affiliate or the UAB health system, they may be fractured. You may not be able to get the data. You may have to collate it yourself. You may be speaking to multiple different people to get this data. I'm sure you all have thought of some effects that would be relevant to your line of research. Some traditional ones, I mentioned diabetes, cholesterol, heart disease, infection prevention, survival, a classic one, life saved, life years gained, quality adjusted life years, and within preferences, utility. We talked about quality adjusted life years and disability adjusted life years. So thinking about utility a little bit more, what it's trying to get at is not just how long did you live, but how well did you spend that time. So you can imagine if you are in a terrible car accident and you are a paraplegic on dialysis, but you live for 10 years, that may not be valued as much as if you're in a terrible car wreck and you walk away and you live a very healthy life for 10 years. So it's trying to adjust for those differences in health outcomes. We rate health states on a scale of 0 to 1, with 0 being equivalent to death and 1 being well, healthy. I kept this in. This is a classic Dr. Kilgore statement, is that are there health states worse than death? And we don't really have a way to assign a value to them, but I think if you would talk to your patients, certainly there are some health states that are worse than death, but we don't have a way to really quantify that. It's just important to acknowledge it. And then are there health states better than well? Similarly, we don't have a way to value, a 30-year-old who is never tired, never irritable, never depressed, can run a marathon off the couch any given day relative to the typical things that people start developing with aging. So science just isn't that far yet. So we'll go back to the cost effectiveness model, and you can see here for this utility assessment, you have cost per life years, and this is where you would incorporate your quality adjusted life year in the triangle, red triangles, which is your payout, if you hear people refer to payout. Cost effectiveness ratios, again, these are very intuitive ways to look at, to compare two interventions, for example. And I mentioned earlier that people use cost effectiveness and cost utility interchangeably, but in general, cost utility analysis should incorporate the quality, whereas cost effectiveness could be time to HIV treatment failure, for example. This is a grid that I think is really helpful, but essentially most interventions that are new, are in this top right quadrant. More effective costs more. That's in general what we see with HIV, cancer meds, etc. If you're over here, sorry, this pointer's a little wacky, interventions less effective but cost more. So we call that dominated. Who wants that? It works poorly and it costs more. The opposite is it's more effective, but it costs less. That rarely happens because pharmaceutical companies know that it's going to be more effective, and so they price it higher. But if you do find that is dominant, you want that. That's the intervention you're going to pick. And less effective and cost less, I mean, there may be some times when you're okay with that, like maybe you want the cheaper statin because it's going to get their cholesterol down to an appropriate range. It's an old drug, it's cheap. It's less effective than the new statin, but it still gets the job done. So this is kind of your general, in general, increasing health outcomes, you generally see it being more costly.
But do you think a lot of the time we're in the upper left quadrant because the head-to-head comparisons just aren't done?
Yeah.
Great placebo.
Yeah. I definitely agree. Okay, so you can do the incremental cost effectiveness ratio if you compare two interventions. So that you can say A relative to B, you get an incremental increase in, wellness at an increase or decrease in cost. So if there's more than one option, you can compare these head to head, and we'll talk more about that. The other option we talked about is if you're just looking at it in isolation without comparing it to another intervention. So here's an example. You have a 30-year-old. Here's his cholesterol, 6.6 millimoles. Diastolic blood pressure is 100. He's a smoker. Lifetime treatment with 20 milligrams of a statin costs $16,000, increases life expectancy by 0.4 years. So the average cost for life year is going to be $40,000. However, lifetime treatment with 40 milligrams per day costs $27,000 and increases the life expectancy by 0.6 years. It's discounted at 5%, which is something that we do to account for diminishing returns over time, essentially. But don't worry about that for the purpose of this talk. But if you do the math for this second option, you see average cost per life year is about $45,000. So you have to take this on a case-by-case basis. For some outcomes, you would be willing to spend more for this incremental change in life expectancy, 0.4 to 0.6 years. This, I think the classic example is these chemo drugs you're seeing that are FDA approved that like for $10,000 more, you'll live like 3 months more on average. You guys have seen these, right? I mean, I'm not an oncologist, but I just see these in the lay press. Like, is it really worth that? And that's why I say you have to take that on a case-by-case basis, disease by disease basis. But this is essentially what an incremental cost-effectiveness analysis would be. And I'll give you a few more examples here as well. So this is Ken Friedberg. This is the Harvard group I mentioned. They're comparing multiple different strategies, 1 through 9, for prophylaxis for AIDS patients. This is decades ago, before we had good HIV treatment. But it just shows, here's a disease, here's 9 different treatment options. Okay, so here's these 9 options. You can see as you go down the list, the cost goes up. And in theory, your effectiveness should go up. But what you can see is that when you go from 3 to 4, you increase costs, but your effectiveness in terms of quality adjusted life months actually dips down, right? So that one's 4 should be dominated, right? And again here, you go from 43.6 to 43.2, but yet the cost goes up, right? So if y'all are like me, you can't do like math in real time. So I don't want you to like be doing these calculations in your head. It's just to show how you could take the interventions you're studying and line them up by cost, line them up by effect, and see how an analysis would potentially affect your choices. This is the exact same data, but what they've done is they've taken, and I think this is really helpful. So this is the same data looking at quality adjusted life months, x-axis, cost over the y-axis. And anytime you have a back step, like you do with number 6, or even number 4, like we pointed out, right? You're increasing the cost without seeing an additive benefit, okay? So just a way to illustrate these real world examples. So, we pointed out a few of these, and if we had gone down to 7, 8, 9, you would see the same thing, so that these are dominated. You knock them out of your equation. So if you're doing a formal incremental cost effectiveness ratio, you would just eliminate these that are highlighted in red. They're dominated and move on to others. So you wouldn't consider them as options based on this data. So sometimes you'll have a weak dominance. This is where, for like example number 7 and really number 9, I mean, you're getting what, an extra month? But look at what you're paying, $10,000, $15,000 more to get those extra months. Is that really worth it to you? And again, that's going to depend on the disease state. But for this example, they said, it's not worth it for that little incremental increase in quality adjusted life month to spend $10,000 additional dollars. So we're going to eliminate that. That's weekly dominated. And then you take the strategies that you have left, 1, 2, 3, 5, and 9, and you graph them and demonstrate that for each additional $1,200, $2,400, you get this additive effect in terms of quality adjusted life months. And that's how you would present your data in sentence form. For, $1,200, you could get an incremental benefit of point whatever 9, whatever the math is. Again, I can't do it in front of you, but you would present it that way. Yes.
And it looks like here they're comparing it to the step prior to it. Is
Yes.
that consistency? You don't compare it to the first one. You always compare it to what came before it.
Yes. And we're deleting those dominated ones, right? So yes, you've condensed it down and you're comparing, it's an incremental with each stepwise. Yeah. And here's graphically, and you should do that to fact check yourself and make sure you don't have an outlier that was included that should have been.
So how do they determine the order? Is it completely based on cost?
Usually, that's how I present it. That's how I've seen this. Because what you're challenging this hypothesis. Is this cost, or is it this cost really justified by this benefit? So very intuitive again, when you think about it. And here's a summary of how that table would look. So what they've done here is they've converted quality adjusted life month to life year, right? There's 12 months in a year. So if you want to do that for the purposes of, really, I think the only value there is if you have other references, that other data in the literature, and you want to be consistent and say, Smith et al. Found that this intervention relative to this provided this additional quality adjusted life months for this cost. But really, I think if the disease state is unfortunately AIDS, back then people were dying on the order of months, then it may be appropriate. Sepsis, maybe more like weeks, quality adjusted life days. So it depends on the disease state. Okay, so this is what we were getting to earlier when I mentioned sensitivity analysis. So whenever you're trying to share this data and convince your audience that your analysis is sound, you need to incorporate alternate scenarios. One-way sensitivity analyses would be when you vary one, sensitivity, no pun intended, specificity, probability, or you can do multiple, you can change all of your variables and your model can synthesize a range of cost-effectiveness outcomes based on multiple simulations where they randomly draw one of those probabilities. And there is software that can do this for you. So it's recommended that you put some standard errors on your cost effectiveness ratios. Again, software can do this for you. And irrelevance of inference. We've talked about this. You have to use inputs into your model that you think are the most relevant. But for all of us, it's going to be really hard to find the exact estimate. Type 2 diabetes in veterans, is that close enough to type 2 diabetics in Kirkland Clinic? If that's the best data you have, you just have to explain that. But again, it's going to be a limitation for some of us. So I mentioned one-way sensitivity analysis. You vary the elements one at a time, holding all of the others constant. So for that syphilis model, maybe I'm going to say, I'm going to give a range of the sensitivity of this first algorithm, 75 to 95% sensitivity, but I'm going to keep the specificity for the ELISA the same, and I'm going to keep the sensitivity for the RPR and the specificity for the RPR the same, and all the other test characteristics will be the same. I'm doing one-way sensitivity analysis. But you can also vary them all at the same time and get a really cool plot showing you all the possible outcomes over like 1,000 runs of your model. This just kind of reminds you what you've put in for your inputs, and then you can get these scatter plots that basically say, if we ran this 1,000 times with like a Monte Carlo simulation, if we ran it 1,000 times, here are the outcomes that we would get in terms of, I don't remember what outcome. It was out of a scale of 2 on your effect and your cost. And here you see in general, the cost is negative. Then another thing that we didn't talk about is the probability and the willingness to pay. So when you think about the cost per effect, you really need to reference, how much are we going to be willing to pay for this new chemo drug? Are we going to be willing to pay $75,000 for an additional quality adjusted life year, quality adjusted life month? In general, people use $50,000. That was historically taken from hemodialysis costs, annual costs, $50,000. But I've seen in the literature people moving towards $100,000 and even $150,000. What is an acceptable willingness to pay for your quality adjusted life year, for example? So really, I usually give a couple. In my papers, I've given a couple options and said, in a scenario where you were willing to pay $100,000, this would be cost effective. However, in a scenario where you were willing to pay $50,000, it would not be cost effective. So again, this is kind of the philosophy of the sensitivity analyses. You have to, in addition to limitations, acknowledge that different scenarios, different payer systems, different perspectives may not be consistent with yours, so you may need to present a range of scenarios. This is just kind of getting more of the same. You have to use the best data available to make the best decisions, to quantify additional costs. You're going to have to acknowledge that there's, even with these sophisticated models, there's still uncertainty. And what would it cost to even obtain better data? I mean, that's an additional cost effectiveness question. How much more do we need to invest in the science before we can even say that this is or is not cost effective? So how is this information used? This question came up earlier. Drug approval, determining benefits covered by insurance. Although I've seen things denied that I've wondered, does Blue Cross Blue Shield realize covering insulin is actually really important, or reducing the cost of this is actually really important. Syringes for insulin, prioritizing programs, treatment decisions. And this is just a reference, not very influential with U.S. physicians, but it's changing. So as we mentioned, in different payer systems, different countries where it's a single payer system, you see a lot more emphasis on, well, what does the cost data say? Which is the more cost effective? And you even see this with our HIV treatment guidelines. We much more quickly adopt novel HIV treatments into our first line treatment recommendations than does the UK or Spain or other countries, because they acknowledge that you're probably not getting a lot of bang for your buck for these costly new drugs. And I'm sure that's not just the case with HIV. So summing up, cost effectiveness analysis allows comparisons among treatments for a specific condition, allows comparison among treatments for different conditions, and it's a guide to decision making. Decision makers have to decide whether a given level of cost effectiveness is worthwhile. CEA rests on a set of assumptions that may not reflect every concern in making choices about treatments and programs. I think we talked about that exhaustively, that this is our best attempt to quantify the potential options. And I wanted to make some acknowledgments here. So a lot of the training I got was through my MSPH in Healthcare Organization and Policy, which was supported by the T32. Dr. Kilgore was my mentor. Dr. Menemeyer has also been very helpful. Teaches the class now, I believe, if anybody's taking the cost effectiveness class. Ken Sag, Michael Mulgavero, Gabrielle Rock, Monica Swanee, Courtney Williams, who shared some of their data with me as well. So have time for any additional questions if anybody has any. Yeah.
Are you aware of research kind of in this